All right, do y'all see my slide here? Yes, no, maybe?
Yes.
All right, here we go. Okay, definition of physical agents. So that's often what we will call a modality is also a physical agent because it's an external something that we're putting on the body. So physical agents are ways and means of applying energy and materials to our client's body, okay? So this is just a wide range of the spectrum of physical agents. We have hot and heat and cold, different things we can do with water, pressure. Sound would be ultrasound because ultrasound is not what you might consider. Some of you might think it's electronic or it's electromagnetic, but ultrasound machines that we use on clients actually work on sound waves. Electromagnetic radiation like lasers and things like that, diathermy, and electrical currents like electrical stimulation, which we'll spend a long time on. And those are pretty fun too. So this is just some broad categories of physical agents, but this is by no means an extensive list. So the term physical agent can be used to describe different things about the modality. It can describe the type of energy it's using, the specific range, or how the modality is applying the energy. And anytime you see the word physical agent, it means the same thing as modality, and modality means the same thing as physical agent. The old term for all these things that we're using used to be modality, and now the new term in the PT literature is they're turning it to physical agent just to make it sound a little bit more fancy and sexy, but it's nothing. Modality and physical agent mean the exact same thing, and you're going to hear me probably call it modality more than anything because that's how I learned it. Okay, now this is an important slide to memorize if you don't listen to me at all today. Physical agents are categorized into three main categories. We got thermal, mechanical, and electromagnetic, okay? So thermal would obviously be hot and cold, so don't forget that cold is included in the thermal category. Mechanical, sound like ultrasound, traction, which like traction machines. STM stands for soft tissue mobilization, so like deep tissue friction massage, trigger point release, even cupping is, I would consider cupping to be a mechanical modality. If you've heard of the cupping, like the suction cups that are that started in Eastern medicine and now it's real big into the Western medicine now. And electromagnetic, which would be like TENS and NEMS, which you'll learn later are different stimulations for pain control or muscle stimulation, and then lasers, which are newer on the market and said to help with pain control. And there is a little bit of anecdotal evidence about that, but we'll talk about lasers when we get there. You'll see my real opinion on that. So let's talk about thermal agents for a second, okay? So thermal agents are hot or cold, and they just transfer energy to a patient to decrease or increase the tissue temperature, okay? So thermal agents are there for increasing the tissue temperature or decreasing the tissue temperature. So obviously, if we want to increase the tissue temperature, we're going to use hot packs. So we're going to, and I'm going to go a little out of order here. We're going to use superficial heating agents like hot packs and hot whirlpools. If we need to get deep down into the tissue, like really deep down, like down to the muscle layer, then we're going to use something called diathermy, which is a different type of machine. We may use ultrasound. Or if we need to cool the body, we would use cryotherapy, which is the fancy way of saying cooling agents. You can use regular ice packs, bags of ice, the gel packs that we have in the freezer at PEMA, which you'll see, which you're probably all familiar with in clinics. ice baths, whirlpools of ice baths, and ice massage, which you'll learn how to do this semester too. Oops, somebody got kicked out of the room. There we go. So that's hot and cold. So let's talk about hot heat just for a second. So thermal agents that increase tissue temperature are most commonly applied to the body to increase circulation, increase metabolic rate, increase soft tissue extensibility or flexibility, so it makes you more flexible, and to decrease pain. So think about like if you've had if you have low back pain, or if you have like a crick in your neck and it's been there for a few days, you may put a heating pad on it or something like that, and that makes it feel better, and then it makes you feel a little bit looser. Well, it is making your tissue looser. It's also working on your pain receptors to help you feel less pain, and it's also bringing in more circulation to the area, more blood flow, which is bringing in more nutrients. So that's how it's helping with the pain and maybe helping heal the area a little bit. Okay. As opposed to cold agents do all of the opposite. So if you have a new injury, what we call an acute injury, you want to keep it with cold. That will decrease circulation, decrease the metabolic rate, decrease the pain still, and it'll decrease swelling and edema. And we'll get into those a little bit deeper next time, okay? Today's just the intro. Okay, so we have mechanical agents too. We have mechanical agents such as traction. If you've ever seen the traction machine that we have in the lab, or if you've ever seen a traction machine used, it is used to pull apart the cervical spine vertebral bodies or the lumbar bodies. And you can use traction to decrease the pressure of those joints, or you can use traction to increase pressure in those joints if you were to compress them. So examples of mechanical agents would be the traction, compression, if people need like compression garments, compression stockings to use on their legs so that they don't, excuse me, so their ankles and their legs don't swell during exercise or walking. Hydrotherapy can be considered a mechanical agent as for different reasons. So people that have large wounds that aren't healing, like diabetic wounds, they have to get their wounds soaked in agitated warm water to allow their wound to get cleaned properly. But the most common type of aquatic therapy you probably know of is exercising in the water. So think about this. If you're in a pool, and let's say you're standing in the shallow end, and then you want to walk across the shallow end from one side of the pool to the other side. Well, if you can't walk your normal speed that you would walk on land because the water is resisting you. Now, if you tried to run across the pool, you're really going to meet a lot of resistance because that water is really going to push back on you. So water can be a mechanical agent too by providing us with physical resistance. So that's why water is such a good way for some people to work out, especially people that are a little bit weaker on land or the people that are a little bit older. They can do a lot more in the water than they can do in the land. But again, this is just an intro to that. We're going to have full days on those later. Electromagnetic. Electromagnetic radiation. So we've got UV lamps, which we don't really use that so much anymore. Used to, when people would have things like back in the old days of our profession, people would be seen by physiotherapists for things like eczema and psoriasis for their skin. And we would put them under UV lamps because, as we know now, you know, like when you have a skin condition, most skin conditions do better in the summertime and when you're out in the sun a lot more. I'm sorry to interrupt y'all. I can hear somebody's mic on and it's real loud in my ears. Can y'all make sure your mics are muted? I don't know who it is. I don't know if it's feedback or if it's somebody not with their mic on. I don't hear it anymore, so y'all must have did it. Thank you. So anyway, but we don't do that anymore because now that's done by dermatologists. So dermatologists take care of things like eczema and psoriasis because that's more of a medical problem, not a physical therapy type problem. And they have creams, and they often will tell them that, I've heard people say that, like, for psoriasis stuff of the face, that their dermatologist told them tanning beds are usually not really recommended because of increases skin cancer, but it can, if you have certain skin conditions, it can help clear up your skin if you use it for a few minutes, and I mean sparingly, often like 5 to 10 minutes twice a week for a few months, and can get rid of skin conditions or keep flare-ups from coming back. Infrared radiation is used with diathermy. Diathermy it used to be an old type of deep heating agent that used infrared and ultraviolet radiation to heat deep tissues. It didn't actually touch the patient, but it was just close to the patient, and it induced a magnetic field that made deep heating occur deeper in the body than the superficial tissues. It got out of style for a while because in the US, because of the size of the machine and just the expense of it, and because moist hot packs were just cheaper. But it's starting to come back a little bit more now. And people that go out, students of mine that have been out on their rotations in skilled nursing facilities, have said that they see diathermy units in skilled nursing facilities more than any other setting. I don't know why that is, but maybe I can figure it out. I'll let you know. Electrical currents, we've got sensory currents and motor currents. So TENS stands for, and you'll learn this later, don't worry about it now, transcutaneous electrical nerve stimulation. And that's electrical currents for pain relief. We also have a pain relief called IFC. We'll learn those in lab together. And then we use different electrical currents for motor stimulation if we want to stimulate a motor contraction. So if somebody is too weak to turn on a muscle or strengthen it by themselves, we can put electrical pads on them, and we can turn on their muscle for them and make them contract their muscle. And we're going to learn how to do that this semester. It's pretty cool. And that's called neuromuscular electrical stimulation. And we usually say NMES or NEMS. NEMS is what you'll hear it called most of the time because it's just a long word. Now, there are going to be a lot of, now the machines that are invented and on the market for PTs and PTAs to use nowadays are very user friendly, and you don't really have to know a lot about electricity and ultraviolet settings to use the machines. But to pass the board exam, you do have to know all those things. So we are reserving a lot of older type electrical stimulation machines because they make y'all input all of your electrical parameters before you start treating your patient. So we're making you learn all of the little pieces because the board exam expects you to know that stuff. So once you pass the board exam and then get out in the real world, if you want to use the really easy machines that don't make you know anything, that's your choice. But for the board exam, you're going to need to know this stuff. And don't let me scare you. It's just a few parameters for every machine, but you're going to be with your modality project that I talked about a little bit, you're going to be making yourself a little cheat sheet and a guide. So you're always going to have this handy next to you. Okay. This is just talking more about the effects of electrical applications. It's going to have, these are all of the different, these are many of the different parameters you're going to have to set. The waveform, whether the wave, if you learned about waves in physics, if sometimes waves are symmetrical, sometimes they're asymmetrical. You have to know if your electrical wave is that, your pulse duration, your frequency of the wave, which is in hertz, cycles per second, or pulses per second, then the amount of power you're using, that just means electricity. Duration means time on, time off. So sometimes the machine will set it to have electricity on for a few seconds and then off for a few seconds to give the body a break. Direction of current flow would be alternating versus direct current, just like any other machine or computer uses AC or DC currents. And then the type of tissue too. And and we'll go more into this later, but look at this little caveat. Fat affects transmission of current also. So in this really for this whole semester that we're talking about physical agents, no matter what kind of agent we're talking about, if we have a patient that has a thicker fat layer over that part of the body that we want to warm up or cool down, we're going to have to use more time with them to let that tissue, that temperature exchange take place, because fat is an insulator. So it's going to take a lot longer for that tissue change to take effect. Okay, so any questions so far? I went through a lot, but this is just an introduction. I'm going to skip this slide because I've already said most of these things in one way or the other. Okay, so now for all physical agents that we use, they are all going to have their own general contraindications and precautions. Now, a contraindication means no, opposite. Indication means, do I use it? So contraindication means would be a reason not to use this physical agent, okay? So each of them are going to have a list of contraindications and precautions, okay? So sometimes pregnancy is a contraindication when you cannot use anything. So for example, a hot pack on the lower back or the abdomen would be a big contraindication during pregnancy, because you do not want to change the tissue temperature of the fetus. So that would be a big no-no. That would be a big contraindication. Malignancy, you never want to put a hot pack or e-stim around an area where there's an active tumor or where there's malignancy. However, malignancy can become just a precaution if the person is already, say they're in stage 4 of their cancer, it's already metastasized, and they are in their final stages of life, they're terminal, and we are just seeing them to make them comfortable. We know that they're not going to get any better. Say that you're working in a hospice environment and you're working with them to keep them comfortable. So there may be a big tumor on their lower back or their shoulder, but you may go ahead and put, for pain relief, a hot pack or electrical stim there, because even though that tumor would normally be a contraindication not to use it under other circumstances, we know that with this person, they're terminal and they're going to die anyway. We're just keeping them comfortable. So that's how it could be a precaution. So just keep that in mind. A pacemaker or any other implanted electronic device, which there's many of them that can be implanted in the body, you'll learn about. You never want to use electrical stimulation anywhere around those, because you can completely change the device, and you could really hurt the patient, especially if it's a pacemaker. You could stop their heart, put them into cardiac arrest. If they have impaired sensations, sometimes that's a contraindication. Impaired mentation means their cognition or their ability to think and their awareness and their clearness of their thinking. So that would be just how confused they are. So if if a person's a little bit confused or maybe not all quite there because of Alzheimer's or dementia, or because they had a traumatic brain injury or a stroke, that doesn't mean you can't use modalities. It just means you need to be careful, because if they need to be reminded every 2 minutes while there's electricity on them and it scares them to death, then that would be a contraindication for eStim. But if you just have to remind them one time every one day at the beginning of every session what the eStim is for, and then they can remember it and then they're okay, well, then that would be okay. But if they're scared to death of it and you have to remind them every 2 to 3 minutes that it's okay, then that would be a contraindication. So you just have to kind of play it by ear sometimes with stuff like that. But with experience, you'll learn those things, so don't worry. Okay, so any questions so far on contraindications? Don't worry, there will be many to come. Contraindications, that is. Okay. Let's see. I'm gonna try to get through the rest of these pretty quickly because they are pretty much just intro, and we'll cover them more in the next few lessons. But choosing a physical agent. So, how do you know what physical agent to choose? Well, you need to look at the primary problem, the primary reason for seeing you. So that would be what we're going to do. So if their reason for seeing you is knee or shoulder pain, then we know we're going to do something to decrease pain or inflammation of the joint. Now, we have to remember that none of the physical agents that we ever use, none of these things that we use can cure a patient. Okay? Nothing cures an injury or a condition except for time and strengthening and range of motion therapy and stretching and lots of strengthening. Okay? Those are the things that heal an injury. Physical agents can help you get there faster, a lot faster, and help you with the pain control along the way and make it bearable so that you can get healed. It'll help the body heal a little bit faster than if you didn't use it on their own. And it can help with pain control a lot too. So just don't think that modalities help with healing and help you. They just help us get better faster. These people would get better if they didn't use modalities, but they may have some problems that if we let them get better on their own. If it took them 6 months to a year to get better on their own, they may develop some other problems along the way. But if we can start with them right after injury using physical agents, we can get them healed and ready to go in 3 to 6 months, and then they're out the door. Okay, so choosing a physical agent. Sometimes there's going to be more than one physical problem. Now, there's always going to be one main problem that we're seeing them for, but most of the time, think about if you're working with a person that's got Medicare, they're retired, they're 65 or older, or they're 60 or older, and they're retired. They're often going to have more than one medical problem. They're going to have pain in more than one area of their body. Or if they fall and break their hip, yeah, that's going to be their main problem. But because of their hip pain and because of the way they're walking now on their painful hip, it's also hurting their back, and it's also causing them to have to walk with a walker, which is putting strain on their shoulder and their wrist. So you have to watch out for a lot of things. So you're going to be treating one. You're going to end up most of the time with most of your patients. You're going to be treating more than one thing at a time. You're going to have one main underlying problem, but then there'll be little things that you're going to be treating too. Don't let that overwhelm you. You get used to it, and at one point it'll get to where if you're only treating one problem and there's no other problem to treat, you're probably wondering, well, this is going to be easy because I only have one thing to worry about. If people have another diagnosis to go along with their main diagnosis, we call those comorbidities, okay? Comorbidity. So when you're thinking about what types of modalities to use, if you're going to use them, you can go by this kind of this little this thinking tree. So think about the goals and the effects of the treatment. So right now, today, you don't know the goals and the effects of the different types of these treatments. We're going to learn those every Monday and Wednesday each week, okay? Today is just an introduction. As you learn the goals and the effects of the treatment, then you've got to ask yourself, okay, I know what and every week we're going to go through different diagnoses and scenarios to go along with each modality you're learning. So then you'll be able to know, okay, I have this diagnosis, and now I'm learning these contraindications and precautions. Can I proceed with this injury? And most of the time, for learning purposes, we're going to say it's going to be yes. Then you will go to the next stage. Is there evidence for using this physical type of agent on this person? Well, let me give you an example. If somebody came in and let's say they're a baseball player, and they tore their rotator cuff and they just had rotator cuff repair surgery, and they come in to see us, and they don't have a lot of range of motion in their shoulder because they're real painful, and they feel really weak, and they can barely move without pain, and they won't let us move their arm very well. There's not a lot of evidence out there for putting a hot pack on a shoulder that's that acute, because honestly, we're going to make it worse. If they're in that much pain, we need to put them. There is evidence in the literature that cold will help with their pain and with their ability to let us work with them there. So if it's a brand new injury, say like a few days to a week after surgery, we're going to be putting cold on that shoulder, because then that'll numb their pain, and then we can start giving a range of motion to their shoulder, and then that will get, and with the decreased pain, they can start doing some simple strengthening with us. And let's don't forget the last little box: cost, convenience, and availability. Well, ice packs, all you use them over and over again. You just stick it in if you're using a bag of ice, it's just a big Ziploc bag full of ice cubes. Or if you're using an ice pack, which most clinics have, which we have at Pima, it's just going to be a frozen gel a bag that you put back in the freezer after every time you're done. And then you let it freeze for another 20 to 30 minutes, and then it's good to use for the next person. Super duper cheap. We're going to skip this. Okay. Now, this is another big stage. This is another slide you need to know for today. If you don't know, so I told you the different types of physical agents. This is the stages of inflammation and healing. Okay. If you didn't, Dr. D is going to drill these 3 stages into your skull this semester in pathology until you hear her chanting it in your sleep. Okay. But I'm going to introduce it to you today. I'm just going to tell you, get ready for it, because it's coming. She's going to repeat it, and you'll hear it in your sleep. The stages of healing always go through these 3 stages. So, and I'm talking about after any kind of injury. I'm talking about a soft tissue injury primarily, okay? So the first stage is always going to be the inflammatory stage. That's where the body goes into its fight or fright mechanism, where the body is freaking out, like, oh my God, there's a big giant neck gash or a cut, or there's a new surgery, there's a surgical wound, there's So it's going to be inflamed. The body's going to send edema to the area, because inflammation and edema to a point is good because it keeps us from moving that part of the body. It immobilizes us. So the body is protecting that part of the body by making it a little bit immobile, so we won't move it, and it'll make it too painful to move. It sends in a lot more blood flow to start getting damaged cells out of the way and bring in more blood and oxygen and nutrients to the damaged cells, and then to replace the cells that are going to die. And then you're moving into the proliferation stage. That's the middle stage. That's the stage where most of your healing is taking place. So this is where we still have a little bit of swelling, but most of the swelling is under control. And this is where most of all of our dead tissue and cells that were hurt are pretty much gone and taken away. And now this is where all the new growth in cells cell growth is taking place. Cells are dividing. We still have a lot extra blood flow to the area, bringing a lot more oxygen and nutrients to the cells, because they're growing, and they are growing faster than the other parts of the body. And then the maturation phase would be the last phase of healing. And this is where the wound would be mature. The cells would be to their mature size and age for that type of tissue. A scar is formed on not just the outside, but on the inside as well. And the scar is pretty tight. The scar is formed and it's healed, and that tissue is not going to rip open again. That scar has grown the skin together, and it's tight, and it's forever and ever a scar. It's not going to rip open. Now, contrary to what some people may say, when you have a physical scar on your body, whether you had to have stitches or not, it doesn't matter what type of scar it is, internal scars and external scars, the scar tissue that forms it's going to be really, really strong, but it's never going to be 100% as strong as that skin was or that tissue was before the injury or the surgery. It might come close, but it's never going to be 100% of its natural strength. It might come close, and it's probably not ever, and it's not going to rip open or anything if it's a mature scar, but it's just not going to be the same strength as regular tissue would be. Okay, so we can go into these a lot, and that's what these go through. So I'm going to fly through these. So in the initial phases of the injury, we're going to use a lot of cold therapy, water to get rid of contaminants, control edema to get rid of swelling and to help with pain. And all these under here, all these bullets are just examples of ways that you could do these things. Don't worry about memorizing it all now. It'll come to you later. Chronic inflammation, that was for the chronic phase of healing. Now in the chronic, that was for the acute phase of healing, more the first few weeks. Then when you move into maybe about a month out and then past, you're in the chronic phase of healing and inflammation. Well, now we don't really have a lot of swelling, but we might have a lot of joint stiffness. Our scar is starting to form pretty well. It's not open. We're getting some more strength and range of motion back, but we're still weak and we're still stiff. So this is our chronic phase of inflammation. So this is where we need hot packs, and we need thermal hot ultrasound, hot water baths to get us warm, because we need to warm the tissue up now to get it more flexible, to bring more blood flow to the area so that the muscles can have more nutrients so that they can contract better and get stronger and things like that. So chronic inflammation and chronic healing uses heat. If you have some of you in here may have back pain that you've had for years. And I would say that I haven't asked any of y'all, but I would guess that instead of using a cold pack on your back sometimes for pain relief, you use a hot pack for chronic pain relief, because that's what seems to help with chronic pain. And that's what most people with chronic shoulder pain, chronic back pain, they have hot heating pads that they may plug in, or moist hot packs, or hot packs that you put in the microwave for a few minutes and warm up. There's all kinds of different ones. You'll learn about the different types next week or the week after. But chronic heat is going to help start promoting more healing. And heat will help promote the proliferation phase too, more of the strength and the flexibility part of that phase, and the maturation. Okay, so that was the tissue stages of inflammation and healing, are a whole different ball game on their own. So pain, we're going to go through a whole lecture on pain in a couple of weeks, okay? But give me 10 minutes here before Dr. K starts. Let me give you a little brief introduction to pain. So we have acute pain and we have chronic pain. Acute pain is going to be more sharp, more tingly, more types of knife and dagger type pain, or chronic pain is going to be more achy, more deep, more kind of dull and always there. Acute pain can kind of come and go. It can kind of get better with hot and cold or with E-stim. Chronic pain is kind of hard to get rid of, kind of that deep pain that kind of comes and goes and takes a long time to go away. And sometimes you're kind of always stuck with it. Referred pain is a type of pain that's coming from an internal organ or another area of the body, but it's actually felt in a different area of the body. So just an example of referred pain, when people are having heart attacks, they'll often feel pain going down their left arm, or women might feel pain during a heart attack under their right scapula. Now that makes no sense to us why they would feel that pain there, because there's nothing going on in their arm. It's coming, the problem is in the heart, but they're feeling it in the arm. That's known as referred pain. It's not coming from it. The problem is not in the arm. It's coming from a different type of part of the body. Okay. There's different diseases can give you different types of referred pain. Malignancy. We talked about we want to avoid physical agents over areas of malignancy unless they're already metastasized and they're in stage 4, and we're just doing it for comfort. Complex regional pain syndrome, also known as CRPS, or often pronounced as Crps for the acronym, is it's an overactivation of the sympathetic nervous system. Think about it as your pain systems are on overdrive and you're hypersensitive to pain. So think about this. The best example I can give you is that people that develop CRPS or Crps, just putting on a t-shirt in the morning or putting on their bra in the morning, the fabric brushing across their skin is so painful that we don't think of a cotton t-shirt or a cotton shirt is going across our skin. It's painful. It feels soft to us, or we may barely even notice it, but to them, it's going to feel like daggers. It's going to feel like fire. So it's going to be hard. It's going to take them a long time to get dressed because it's so painful. And they have to have a lot of help with that because they can't do that by themselves if they have Crps. So that's just an example of what can happen with Crps. So these are different types of pain. We'll go through these in a lot more detail in a couple of weeks. We'll go through those. This is just a chart showing you that as tissue temperature increases with heating modalities, collagen which is our main connective tissue in our bodies, gets more extensible or more flexible. So if you want to stretch somebody out and make them more flexible, get more range of motion, you always want to use heat, or that's why we always warm up before an exercise. Muscle tone is the amount of, has to do with the nerve conduction and how much the muscle can contract. I'll leave it at that for now, because there is a such thing as abnormal muscle tone. But if you want to have, if you're lifting or lifting weights, or you're having your patient do some strengthening, you want to make sure their muscles are a little warmed up and not cold, because a warm muscle can do more than a cold muscle. Remember, we talked about evidence-based practice back in Intro to PT, that just whatever we do in our daily practice, we want to make sure that there's scientific and scholarly evidence for it. So everything that we're going to talk about, every type of physical agent we're going to talk about this semester is going to have, I'm going to challenge you to look up the evidence for it. You are going to have to write one paper for me this semester on it's going to have to be an evidence-based practice paper, and it's going to be based on any of the modalities that we go over this semester. It's going to be any of your choosing, or any other modality that's out there in our field that's in use that we might not have time to go over. So things like cupping or dry needling, those are modalities that we're just not going to have time to go over until in this class. And in this class, we'll touch on them in semester 5, but they're perfectly fair modalities to write on for your paper for this semester. So if you chose to write your paper on that, that's totally fair game. Just run it by me if you want to, if it's something that's not on our syllabus. Just remember, the goal of evidence-based practice is to give the best patient care by giving care that has been scientifically proven to work. Make sure that you're using a physical agent that's cost effective. Don't choose something that is just so expensive to use. Don't just choose it because it's the newest and latest gadget out there, because it might be a really effective tool, but is there a cheaper way for the patient to get the same outcome without having to pay so much of a copay or their insurance? Or if they're paying cash pay, can you get the goal done a cheaper way without having to use such an expensive modality? Just remember, I'm not going to go through all these things. This is just the International Classification of Functioning again, about impairments, disabilities, and handicaps. I'm going to let you review those again on your own. This is a little flow chart again on your own to review. This is a good flow chart. If you can't remember the difference between an impairment, functional limitation, and a disability, look at this chart and keep the slide handy. This will be a good one. ICF again. This is just the roles of physical agents in rehab. One of the things that I want you to know from this slide, and we're almost done, don't be one of those therapists, or don't become one of those clinics that they're really heavy on modalities, that every time the patient comes in, you're using modalities and half your session has to do with a modality, because that's not why they're coming to see you. They can do a modality at home by themselves. Once we teach them how to use eStim, they can buy an eStim machine off of eBay. They can buy a hot pack or a cold pack. That doesn't take a lot of skill. It takes us our knowledge and our degree to teach them how to use that. But after they've become competent in it, we let them go for that on their own, and we move on to other things that they can't do on their own. Okay. So, just remember, don't always do modalities all the time. Use them sparingly and only as needed. If and just an example, if you're working with a patient and a rotator cuff patient, let's go back to that. And let's say they're in their chronic phase where you would usually heat them up before doing all their stretches and their exercising because they're in that stage of healing. Well, maybe have them heat up their shoulder with a hot pack before they even get to see you. Or maybe when they get to the clinic, when they're in their waiting room, have them doing some of their stretches before they see you, so that when you get to them, their body's already ready to go, and you don't have to use time on modalities and waste their time doing that. Okay. And make sure that that you're only using modalities as an adjunct to actual hands-on care. Okay. Physical agents should never be the main part of your session. They should only be a small part. They should be used as something to help us get to a goal. We still should be using therapeutic exercise, functional training, manual exercise and mobilizations, neuromuscular exercise, which you're going to be learning all those things soon, so don't worry about it yet. Those are the things that are going to get people better. Physical agents just kind of help jumpstart those things sometimes. Just a few caveats, and then we'll be done. Make sure that your doctor hasn't given you any precautions. Make sure that you go through your patient's medical history pretty thorough before you use any kind of medical agent, because the doctor's prescription is probably not going to say use modalities, but beware a pacemaker. So if they have a pacemaker, you need to read that to know to not use e-stim in their chart. I mean, on them during their treatment, because what if you didn't read that and it's not on the prescription, and you give them e-stim for pain relief in their shoulder, and then you do something to their pacemaker? Well, you're going to be in trouble. That patient's going to be in bigger trouble than you, but you're in big trouble. So make sure you read all those things before you do anything, because there could be things that the doctor didn't catch. There could be things that the PT didn't catch, that the PT might assume that you might catch on your own. If you catch something like that, just make sure you run it by the PT first. I would say, hey, I noticed in their chart that they have a pacemaker, and I just want to let you know you put in your plan of care, I could use e-stim, but because he has a pacemaker, I can't use e-stim because that's a contraindication. You would run that by your PT. I mean, your PT can't argue with that because that's a contraindication. So you've done your due diligence, and then you go treat your patient a different way. And then you document that you told your PT that, and all is well with the world. And welcome back to school. All right. So let me stop sharing and record.